Clinical chemistry, hypothalamus, and pituitary hormones. The pituitary is sometimes called the master gland. It secretes hormones that regulate the other glands of the endocrine system. It's needed for metabolism and gonadal, thyroidal, and adrenal function. A transponder that transmits neural input into a hormonal or endocrinological product. Distinguishing features of pituitary function are feedback loops, pulsatile secretions, diurnal rhythms, and environmental or external modification of its performance. There are three distinct parts of the pituitary. The anterior pituitary, also called the adenohypophysis, it's the largest portion of the gland. There's an intermediate lobe, or pars intermedialis, and that has very little functional capacity. And then there's the posterior pituitary, or neurohypophysis. This arises from the diencephalon of the brain. It's responsible for the storage and release of oxytocin and vasopressin. And vasopressin, another word for that is antidiuretic hormone, abbreviated ADH. This particular relationship needs to be emphasized a little bit more. So the hypothalamus produces the hormones that are released from the posterior pituitary. The posterior pituitary only stores those hormones until it's time to release them and then releases them. So there's a tight relationship between the hypothalamus and the posterior pituitary. So this is a diagram showing the location of the pituitary and the relationship between the hypothalamus and the posterior pituitary. I mentioned feedback loops. So a simple feedback loop can be seen here. So for example, the hypothalamus is going to release thyrotropin releasing hormone, which stimulates the pituitary to release thyroid stimulating hormone. Thyroid stimulating hormone will then stimulate the thyroid. Once the thyroid has produced enough T4 hormone, thyroxine T4, will then work as a negative feedback mechanism to stop the pituitary and stop the hypothalamus so that these hormones are no longer released. Peptides and bioactive amines are the most common products of the hypothalamus. Hypothalamic hormones often have multiple actions. TRH stimulates the secretion of both TSH and prolactin, so thyrotropin releasing hormone stimulates the secretion of thyroid stimulating hormone and prolactin. Gonadotropin releasing hormone, or GnRH, stimulates both luteinizing hormone and follicle stimulating hormone production. Somatostatin inhibits growth hormone and thyroid stimulating hormone release from the pituitary. Vasopressin, also known as ADH, stimulates water metabolism and adrenocorticotropic hormone secretion. I highly recommend that you write down these abbreviations and write down what each one of these hormones does. So take some time to kind of write out the full words, not just the abbreviation, and then that way you know what they stand for and you can study them kind of both ways. The anterior pituitary hormones, the anterior pituitary itself is larger and more complex. The hormones are larger and more complex than those from the hypothalamus. There are two types, tropic hormones and direct effectors. Tropic hormones act on another endocrine gland. Growth hormone affects the substrate metabolism and stimulates the liver to produce growth factors. Direct effectors act directly on peripheral tissue. So luteinizing hormone directs testosterone production from Leydig cells. Follicle stimulating hormone is responsible for ovarian recruitment, folliculogenesis, and spermatogenesis, so the maturation of the egg. And spermatogenesis is production of sperm. Thyroid stimulating hormone directs thyroid hormone production from the thyroid. And adrenocorticotropic hormone regulates adrenal steroidogenesis. Pituitary tumors. So according to autopsy studies, about 20% of people harbor clinically silent pituitary adenomas. Findings are consistent with pituitary tumors are observed in 10% to 30% of normal individuals undergoing MRI exams. Pituitary tumors account for 91% of lesions from patients who have undergone transsphenoidal surgery. Physiologic enlargement of the pituitary can be seen during puberty and at pregnancy. So now we're going to talk about each specific hormone from the anterior pituitary. So starting with growth hormone. Amphibolic influences both anabolic and catabolic processes. It allows effective transition from a fed state to a fasting state without shortage of substrates. Directly antagonizes the effect of insulin on glucose metabolism. It provides hepatic gluconeogenesis. Hepatic is referring to the liver. Gluconeogenesis, genesis is the creation of something. Gluco is referring to glucose. Neo means new. So we're taking something like a lipid and converting it into glucose to produce glucose. It stimulates lipolysis, or the breakdown. Lysis is to break apart, so lip is referring to fats, to break apart fats. It enhances protein synthesis in skeletal muscle and other tissues. It stimulates the production of insulin-like growth factors. Testing is based on dynamic physiology of growth hormone axis. Testing for autonomous production of growth hormone relies on normal suppressibility of growth hormone by oral glucose loading. So strategies to stimulate growth hormone: insulin-induced hypoglycemia, combination infusions of GHRH and amino acid L-arginine, infusion of L-arginine coupled with oral L-dopa. Acromegaly results from pathologic or autonomous growth hormone excess. In most cases, a pituitary tumor. Causes the following. So acromegaly causes gigantism, bony and soft tissue overgrowth, progressive enlargement of the hands, feet, mandible, and skull, arthritis, diabetes, hypertension, atherosclerosis, muscle weakness, sleep apnea, and a shortened life expectancy. Because patients with acromegaly also have a greater lifetime risk of developing cancer, cancer surveillance programs, especially regular colonoscopy, are recommended. Growth hormone deficiency occurs in both children and adults. In children, it's usually genetic or it's due to tumors. In adults, it's the result of structural, functional pituitary abnormalities. It results in growth failure in children, sometimes termed pituitary dwarfism. Various genetic defects are associated, so recessive mutation in the GHRH gene, the failure of GH secretion, loss of the GH gene, GH insensitivity, and structural lesions of pituitary or hypothalamus. Prolactin. So prolactin is structurally related to GH and placental lactogen. It's considered a stress hormone and has vital functions in reproduction. Prolactin inhibitory factor was once considered a polypeptide hormone capable of inhibiting prolactin secretion. Dopamine, however, is the only neuroendocrine signal that inhibits prolactin, and it's now considered to be the elusive PIF. Its physiologic effect is lactation, so it promotes milk production and lactation. Excess prolactin usually leads to hypogonadism. Hypo means less. Gonadism is talking about the gonads, so small gonads. A prolactinoma is a pituitary tumor that directly secretes prolactin. It's the most common type of functional pituitary tumor. Clinical presentation depends on the patient's age, gender, and tumor size. Some premenopausal women, usually menstrual irregularity or amenorrhea. Amenorrhea is stopping the menstrual cycle altogether. Infertility and galactorrhea. In men or postmenopausal women, it causes headaches or visual complaints. Other causes of hyperprolactinemia include the pituitary stalk interruption, dopaminergic antagonist medications, thyroidal failure, renal failure, polycystic ovary syndrome. Clinical evaluation of hyperprolactinemia, careful history and physical examination, obtain TSH and free T4 levels. So if you remember, the thyrotropin releasing hormone stimulates the release of thyroid hormone and prolactin. So you want to measure these levels. If a pituitary tumor is suspected, you carefully assess other anterior pituitary function and evaluate of cellular anatomy with MRI. The management of prolactinemia or prolactinoma. Therapeutic goals include reduce the tumor mass, restore normal gonadal function and fertility, prevent osteoporosis, and preserve normal pituitary function. Therapeutic options include simple observation, surgery, radiotherapy, medical management with dopamine. Idiopathic galactorrhea, lactation in women with normal prolactin levels, diagnosis of exclusion. Hypopituitarism. So failure of either the pituitary or the hypothalamus results in loss of anterior pituitary function. So pan-hypopituitarism is the complete loss of function. Monotropic hormone deficiency is loss of only a single hormone. Mono means one, so referring to one hormone has a deficiency. It's associated with low or normal levels of tropic hormone. Both tropic and target hormone levels should be measured when there's any suspicion of pituitary failure. If one secondary deficiency is documented, you want to search for other deficiency states and the cause for pituitary failure. Etiology of hypopituitarism. Pituitary, paracellular, metastatic, and hypothalamic tumors. Postpartum ischemic necrosis of the pituitary. So postpartum after giving birth. Ischemic is talking about a constriction in blood flow. Necrosis is talking about degradation of tissue or death of tissue. And they're talking about that happening in the pituitary. Infiltrative diseases, hemochromatosis, sarcoidosis, and histiocytosis, fungal infections, tuberculosis, syphilis, lymphocytic hypophysitis, and severe head trauma, pituitary surgery or radiotherapy. The treatment of pan-hypopituitarism includes thyroxine, glucocorticoids, and gender-specific sex steroids. Posterior pituitary hormones. So posterior pituitary is an extension of the forebrain. It represents a storage region for oxytocin and vasopressin. So starting with oxytocin, oxytocin has a critical role in lactation. It stimulates milk letdown. So prolactin stimulates the production of milk. Oxytocin allows the milk to be ejected from the ducts. It likely plays a major role in labor and parturition. Synthetic oxytocin, or Pitocin, is used in obstetrics to induce labor. It has been shown to have effects on pituitary, renal, cardiac, and immune functions. Vasopressin, also known as antidiuretic hormone, ADH, is a cyclic nonapeptide structurally similar to oxytocin with an identical disulfide bridge. It differs only by 2 amino acids. The major action is to regulate renal free water excretion and water balance. So antidiuretic means it's against. Diuresis is the loss of water, so it's against the loss of water. This acts on the kidney tubules to reabsorb water so that water is retained in the body. A potent pressor agent and affects blood clotting. Hypothalamic osmoreceptors and vascular baroreceptors regulate the release of vasopressin from the posterior pituitary. A deficiency can lead to diabetes insipidus, which is characterized by excessive urine production, polyuria, and intense thirst, polydipsia. If you think about it, antidiuretic hormone causes you to retain water in the body. So if we lose that, or we have a deficiency of that, then you're going to lose water. So the opposite of retaining water, losing water. So excessive urinary production and excessive thirst.